Good afternoon, everybody. Welcome to the first edition of our Ethics Grand Rounds for fall semester of the 22-23 academic year. I'm Deborah DeBruin. I direct the Center for Bioethics, and I'm really pleased that you're all joining us for what I think is going to be a really fascinating and important conversation about healthcare in correctional facilities. Let's begin by just covering a little bit of logistic information to facilitate our time together today. If you have questions for the speaker, please use the Q&A function that you see at the bottom of your screen to ask questions. If you have follow-up questions, then use the Q&A function again to ask your follow-up. You can put your question in the Q&A at any time during the talk. We will address questions at the end of the talk, but you don't need to feel any particular need to wait until the end to add your question there. You can also use the Q&A function if you are having any technical difficulties, and center staff will address those issues privately with you through the Q&A function. This event is being recorded, and that recording will be available at the Center for Bioethics website within a few days. And I want you to know that there will be a couple of ways that you can access the evaluation for the event. It will pop up in your web browser when the event is over, and so you can complete it right away if you choose, or you'll receive it as well through a post-event email. Next slide, please. So there are a number of groups that can receive credit for participation in today's grand rounds. So let's start by talking about interprofessional education credit. This is credit for health professions students here at the University of Minnesota. This event has been approved for IPE credit. And if you would like to pursue IPE credit, please complete the reflection form that's linked in the presentation details document. For those of you who are health professionals or other professionals who wish to request a certificate of attendance for continuing ed credits, you can complete the form that's linked in the presentation details document, and it may take up to 3 days for us to get those credits to you. I just need to note that given the requirements that are imposed on us from the accrediting bodies, that you have to attend a minimum of 75% of the talk to receive your certificate. Biomedical engineering students, please email the email address on the slide here to indicate your attendance, and you will be able to get credit for your participation in today's event. Next slide, please, Kayleen. So a bunch of thank yous. I'd like to begin by thanking our co-sponsors for today's events, the Center for Bioethics, partners with other units at the university on every event that we host. And this time is certainly no exception. As you can see, we've had great support from partners at the university, the Med School, the Human Rights Center, the School of Nursing, the School of Public Health, the Program in Health Disparities Research, the Center for Anti-Racism Research and Health Equity, and the Robina Institute of Criminal Law and Criminal Justice. We're really pleased to bring together this really interdisciplinary and interprofessional group of programs to help bring this event to you. I also need to say thank you to center staff, especially our event coordinator, Kayleen, who's done fantastic work to help coordinate here, and much gratitude to center staff. Next slide, please. So without further ado, let's turn to the topic at hand. I am really pleased to be able to introduce to you today Dr. Brendan Saloner, who is here to talk to us about human rights and healthcare behind bars in the time of COVID. Dr. Saloner is a Bloomberg Associate Professor of Addiction and Overdose in the Department of Health Policy and Management at the Johns Hopkins School of Public Health and core faculty in the Berman Institute of Bioethics at Hopkins. He focuses on improving the healthcare safety net for low-income and disadvantaged populations, with a special emphasis on people who use drugs and people in the criminal legal system. And I really want to welcome him here today. We're very excited to have you, Dr. Saloner. And at this point, I am going to turn it over to you.
Well, thank you so much for having me and for that warm introduction. I am truly feeling the love, and I am so delighted there are so many people joining us today during a lunchtime seminar without any food. So if you find me in Baltimore or in DC where I live, let's break bread sometime. I'd really like to follow up with anyone who's interested. All right, without further ado, let me get to my slides. And I'm going to just put this into presenter mode. All right, great. So hopefully everyone can see the slides, and I am going to advance and just to acknowledge my fantastic collaborators listed here. And the funder for this project, the Greenwall Foundation, was kind enough to give us a Making a Difference grant, which was really the impetus for the thinking and the work that was done in this project. And I want to just emphasize that the views that I present here are my own and not necessarily those of the funder. So a little bit of a roadmap to my talk today. I'm going to start by talking about the pandemic and what that revealed about carceral healthcare. I'm going to introduce the idea of equivalence as a kind of a theory of how to raise the standard of care in carceral settings, and then talk about what that means in practice. I'm going to offer a proposal for what it would mean to raise the standard in the United States, focused on using Medicaid as a standard and improving oversight. And I'm going to close with some challenges that lie ahead. Many of you perhaps are already familiar with data like these. This comes from a study that we published in JAMA in 2021. It's actually an update of another study that I had led that was published in the early months of the pandemic, showing the profound impact in terms of cases and deaths in US prisons. And I think, you know, the elements of this story are fairly well known. But just to emphasize that throughout the pandemic, and even in the periods of really heightened spread overall in the US population, we saw massively higher case rates in prisons, on the order of 5 times higher, and death rates that, after you account for the differences in the age and sex distribution of prison populations, came in at about 3 times higher. So the impact of COVID-19 was felt very, very profoundly in carceral facilities. And this actually was very widely predicted at the start of the pandemic. Many people, I was one of them, but certainly many others, raised the alarm bells that this was a disaster waiting to happen, because we all saw that the conditions of close confinement and limited access to basic supplies in many facilities was just creating circumstances that were ideal for widespread propagation of the virus. But actually, the pandemic is only part of the story. And so I wanted to talk for a minute about Clayton Mcrae. So this is Clayton Mcrae, a reporter from Vox, told his story in an article that was published over the summer. So Clayton had survived a shooting that had left him with a hole in his foot that required daily wound care, basically to remove dead tissue and just to keep the area clean. But he had been incarcerated, been out in the community, had made incredible strides in terms of rehabilitation, had been able to walk with his foot, and then had to go back into jail because of a small drug violation. He went into the Allegheny County Jail, and during his time in jail, the pandemic hit, and basically Clayton's access to medical care was effectively shut off. He didn't get his daily wound cleanings. His wound, in fact, became very severely infected. By the time that a real medical doctor saw him, it was too late. They diagnosed osteomyelitis, and so the infection had spread down to the bone, and an amputation was required. And I think, the story is galling on its own. One of the details of the story that really stood out to me is that the staff in the jail denied Clayton access to antibiotics late in the infection when it was clear that an amputation was going to be required, because I guess they justified that the foot was a lost cause. I'll just give you a quote from the story. The pain and the smell from his foot made it almost impossible to eat. It also kept him awake, and the only way he could snatch brief moments of sleep was to pull the blanket over his head to block the stench. Later that spring, jail doctors diagnosed him with osteomyelitis, a bone infection, but Mcrae says that they didn't tell him about the serious condition until weeks later, and the course of medication they gave him was too brief to effectively treat it. So I don't want to presuppose too much knowledge about mass incarceration in the United States. I just want to say a couple of orienting things. So this is a busy picture, but it tells you who is incarcerated sort of by populations. So the main place where people are incarcerated in the United States, there are about 2 million people who are incarcerated on any given day, are in state prisons. So these are people who have been typically sentenced to be in prison for at least a year. And then the second largest population are in local jails. So these are typically short stay populations. The largest segment of that group, it's hard to see it on this slide, are people who have not been convicted of any crime yet. So often they're awaiting trial or some kind of adjudication. Many of these folks will only spend a night or two, but some of them may spend, up to a year or more. And then the third largest slice of the pie is federal prisons and jails. So the federal government also maintains its own system of incarceration. And then smaller segments are accounted for by the youth system, ICE detention, and involuntary commitment. And probably this is also somewhat known to this audience, but seeing it visualized is important. So incarceration in the United States just eclipses any other peer country. It's the rate per 100,000 is 664 Americans in the United States. The country that comes second, the United Kingdom, is at 129. You can just see how it goes down in some other countries. And also probably well known to this group is the disparate impact of incarceration on Black, American Indian populations in particular, that there is just an incredibly high excess incarceration rate in those populations. So the focus of my talk is on healthcare. And the first thing to know about healthcare in jails and prisons is that standards just vary very much widely for incarcerated people, and they did so before the pandemic. So each of those separate state prison authorities, so there's 51 of them if you include DC, or the local jails, of which there's about 2,000, effectively gets to set its own standards. So there's no national standard that they have to follow, no list of medical procedures or treatments that they have to cover. And alongside that, there's no major funding source or oversight really from the federal government in terms of, what must be covered by these entities. And so what we see is incredibly disparate access and services for a range of treatments. Widely documented for the medications that cure hepatitis C. I've done a great amount of work on the variation that we see in access to treatment for opioid use disorder, mental health treatment, and the list goes on. And one other thing I want to say is that the population of people that is incarcerated is not well. So we don't have a huge amount of data on health and healthcare behind bars. But what we do know, and this comes from the Bureau of Justice Statistics survey of prison inmates, is that rates of asthma are about 2 times higher in state prisons than among US adults. Massively higher rates of hepatitis B and C and HIV. And then just to sort of give a little bit of an intuition for how much healthcare spending varies across states, which is a little bit of a proxy for how much healthcare is actually delivered in prisons. You can see that the range goes from about $2,000 in the lowest spending state to about $20,000 in California at the top. And the average, and this was in 2015, was about $5,700 per resident per year. So some of you might know that there is some constitutional case law. The U.S. Supreme Court has decided cases about healthcare for incarcerated people, and there is a sort of an idea that there must therefore be a standard of care that exists in jails and prisons. So if you look at the kind of the defining case on this issue, Estelle v. Gamble, which was decided by the court in '76, they lay out a standard that serious health needs cannot be met with, quote, deliberate indifference. So to really demonstrate that someone's constitutional rights have been violated, it has to be substantiated that their medical needs were met with indifference, and not only that their medical needs were met with indifference, but that indifference was deliberate. So in fact, sometimes there have been cases where it has not been adequately demonstrated that the treatment or the mistreatment of someone's medical needs was deliberate, and therefore the court has ruled that people didn't necessarily have the right to the health care in that situation. So suffice it to say, we don't have an affirmative standard of care, and that leaves a lot of room for discretion. And then separate from that, in the Clinton administration, the Prison Litigation Reform Act was a law that went into effect that made it much more difficult for incarcerated people to sue for substandard healthcare. A lot of procedural things gum up the works and make it difficult for individual incarcerated people to sue the place where they are incarcerated. So in our paper, we just sort of entertain the idea that in the absence of a federal standard, perhaps there's other sources of standards or norms that exist. So certainly many, but not the majority of carceral facilities are accredited by bodies like the NCCHC, the National Commission on Correctional Healthcare. So, you know, an NCCHC accredited facility has to demonstrate that they have met certain elements of care, and there's a lot of manuals that lay that out. But NCCHC accreditation is voluntary. It costs money. Accreditation, the accreditor has to sort of operate on the good graces of the carceral facilities. So in terms of how much they are really able to stringently enforce the delivery of healthcare and enforce quality standards, I think that's very unclear. So we reject that idea. The other idea that we reject is that norms of healthcare could come from the entities that very commonly are contracted to provide healthcare. So there's a misnomer that a lot of people are incarcerated in privately operated prisons. That's actually not true. Most carceral facilities are operated by state or local government. But what is true is that many of the healthcare providers that operate in those facilities come from outside, often for-profit companies that bid to basically have the contract. And so these companies could be a source of norms for healthcare. You know, they have standard contracts that they use. Those contracts could lay out certain elements of services that they would consistently provide. I think the reality is that oftentimes the bidding process works to the lowest common denominator. So the vendors compete to be the lowest cost provider, and then they have to basically staff their healthcare unit using the lowest cost provider options they can, meaning that they understaff and oftentimes don't have the full spectrum of health providers that are necessary. The third source of norms that we thought about were, you know, medical professional societies. If you look to individual medical specialties, many of them have certain standards that health providers must meet when they care for incarcerated people. And, you know, it would be a violation of medical ethics for providers to not follow those standards. But unfortunately, those standards are hard to enforce, don't operate at the level of a facility, and don't necessarily encompass the full spectrum of people who deliver healthcare in jails and prisons. So again, we sort of rejected that idea. So then turning to international human rights doctrine, there is a set of principles for the treatment of incarcerated people known as the Mandela Rules. They're named, of course, after Nelson Mandela, probably the most famous political prisoner of the 20th century. And they lay out a set of rules that would encompass the fair treatment of incarcerated people. And one of those kind of centering rules is this idea of medical equivalence. So the way it's framed in the Mandela Rules is that prisoners should enjoy the same standards of healthcare that are available in the community and should have access to necessary healthcare services free of charge without discrimination on the grounds of their legal status. And then other of the Mandela Rules cover things like adequate staffing, emergency preparedness, access to hygiene, due process in asking for certain kinds of medical services to be delivered, professional ethics, and care for people undergoing reentry. So we think this is the right standard. The ethical justification for equivalence is that if a person is incarcerated, whatever else we might think about sort of the diminution of their rights during that time, they don't and should not have a diminution of their basic entitlements to healthcare. And the thing that we should look to is what healthcare should people with similar health needs on the outside world receive. And then this other idea that in society, health needs should be met roughly in relation to the urgency and vulnerability of the people who have those needs. So I think both of those principles justify or flow from the principle of equivalence. One might argue, and I don't reject this idea, that equivalence doesn't actually even go far enough. So just a few thoughts or caveats. So equivalent healthcare is not the same healthcare. I often remind my kids that me treating them equally doesn't mean that they always get the same thing. So sometimes some groups are needier than others. So to provide healthcare that's equivalent for incarcerated people would, of course, mean that there would be more care for asthma, HIV, and hepatitis C, since all of those things are more prevalent in carceral facilities. The one thing that equivalence cannot provide is full choice and autonomy, which are things that when you're not incarcerated are considered sort of cornerstones of fair and equitable healthcare, that we do have some choice in what we get treated and how we get our medical treatment. Some of that can exist on the inside, but there's many ways in which that is a constrained ideal. And then, and this is an idea that I want to come back to, that carceral healthcare should also cover and encompass the structural or social determinants of health. And actually many things that we don't think of as medical get medicalized in jails and prisons. Like if you want to have access to a bottom bunk, or even if you need ice chips, oftentimes those requests flow through the medical provider. So some of these things actually are already medicalized, but many things that affect health don't get determined through medical care on the inside. And we should, reflect on that question. So other countries have actually made good on the ideal of equivalence. The standards of human rights that come from the Mandela Rules are actually written into prison law in many European Union countries, and there's a whole kind of regime of oversight that ensures that those standards are met in public reporting about whether care is indeed equivalent. In the United Kingdom, which has a national health service, they say that the prison authority must give prisoners access to the same quality and range of healthcare services as the general public receive from the NHS. So surprise, surprise, the United States does not have a foundation for the European style regulation. As noted, there's no binding legal oversight on carceral facilities. And I think this is the interesting part. We have no community health services benchmark or nationalized source of funding, right? So the other problem with trying to actualize equivalence in the United States is that equivalent to what? Like in many states, there are still thousands of uninsured people and huge gaps and disparities in what people experience in our countries with sort of disparate protections in the community that don't exist in Europe, right? If you live in Great Britain, mostly everybody is covered under the NHS. We have a sort of piecemeal system in the United States that leaves many people unprotected. So the problem that interests me is, like, given this very non-ideal starting point, how could we bootstrap our way toward a national standard or something approaching a national standard? And the place that I would want to start is with Medicaid. So Medicaid, when it was signed into law by LBJ, you can see him there looking a little grumpy, but signing it into law in 1965, was established as a program that was really restricted categorically to certain groups, the poorest in the country, elderly and children, and completely left out most adults. Fast forward to the signing of the ACA in 2010, and a lot of things happened between 1965 and 2010. But the ACA creates a foundation for states to then expand their Medicaid programs to all adults with incomes below 138% of the federal poverty line. And it's hard to really understate the implications of this for people who are involved in the criminal legal system, because most people who are incarcerated or coming back from incarceration are very low income people and would qualify for Medicaid under this eligibility criteria just based on income. But the important thing to know is that since 1965, the Medicaid statute has included what's known as the inmate exclusion. So the inmate exclusion essentially says that Medicaid shall not pay for services for people during a period of incarceration, with very limited exceptions. And the inmate exclusion has actually never been repealed. So, given this, why Medicaid? Well, one thing to say, and I think, this is the area where policy has been moving very rapidly in the last few years, is that we're now in a moment where we could be seeing a complete or at least a partial repeal of the inmate exclusion. So a law called the Support Act in 20 new federal options for providing some care for people during incarceration as they come into reentry using Medicaid dollars. And then the most recent sort of dynamic or dimension of this is that there are 10 states right now that have pending what's known as 1115 waivers to the Centers for Medicare and Medicaid Services, asking for some flexibility from Medicaid around the inmate exclusion. So I think we'll see very soon that some flexibility will be granted around this. Then sort of the thing that advocates are most excited about is was in the Build Back Better legislation. So hard to know exactly what's going to happen, but it has some bipartisan support, and that would be the Medicaid Re-Entry Act, which would essentially repeal a large amount of the Medicaid inmate exclusion. Even with the exclusion in place, though, there's been a lot more action in terms of making sure that people who had Medicaid prior to incarceration come out with their Medicaid benefits completely intact on the day that they leave. So, there is a sort of a standard to look to if you're trying to say, well, what would be equivalent for people who are incarcerated? The most natural sort of analogy is what they could have in the community with a Medicaid card. And if you think about the evolution of the Medicaid program, it has a much more consistent set of benefits and coverage than in the past. So a lot of the growth in Medicaid in the last few decades has been in ensuring that across states, there's much greater consistency in the set of things that a Medicaid beneficiary can have. Of course, there's still a huge amount of variation. If you've seen one Medicaid program, you've seen one Medicaid program. But there has been, through statute, a much greater attention to providing consistent benefits. So the way that I look at it is that we're not quite European, but we're trying. This is the Eiffel Tower in Vegas. So, we're not going to do something totally European style, but I think there's ways to sort of create little experiments in the US that that are proofs of concept of what the European model might look like. Let me turn then to the idea of external oversight. So external oversight encompasses a lot of things, and this is a big topic, so I'm probably not going to get into all of it. But at its core, what external oversight means is that you have some independent external mechanism to oversee either the management of the institution itself or to deal with issues of treatment of incarcerated people or violations of people's rights. The minimal thing that an oversight body can do is reporting. It can collect information and disseminate it and hopefully put it into the public domain for the use of advocates. But more substantively, what an oversight body can do, and this is what they do, for example, in Her Majesty's Inspectorate in Great Britain, is they enforce standards. They come in, they make inspections, they find violations, and they report them, and then the facilities have to remedy those deficiencies in their standards of care. So, this is an important idea because I think that the Medicaid style standards alone will not provide a guarantee of quality services for people who are incarcerated. A lot of things are shrouded in the dark in incarceration. So we need oversight basically to come in and shed light on deficiencies to raise the standard of care and to ensure that there's some quality. Oversight has been written extensively as a topic, but the idea of health care oversight in carceral facilities has had somewhat less attention. And it could mean a few different things. So one of those things is this idea that I alluded to of external transparency. So like, you have some good governance, you audit, you make sure that there's no corruption of the funds that are provided for healthcare, that they go to where, they're expected to go to. That is a sort of a function of oversight. Another function of oversight is what you might think of as procedural justice. So ensuring that there's due process, that when people ask for certain services and there's denials of coverage, that goes through a rational process, that wherever possible, the perspectives, values, and needs of people who are incarcerated are taken into consideration. And generally that people who are affected by the decisions of the healthcare entity have some say in that process. And the third, and this is sort of elusive, is the idea of quality improvement, which is a whole, body of healthcare studies. So there's a little bit of a tension here because quality improvement is really about creating a culture of quality healthcare. And some of that necessarily or probably optimally happens internal to the healthcare provider. Like it's not, there's this sort of tension between naming and shaming bad actors and identifying deficiencies in the delivery of healthcare, letting the healthcare team know about them and allowing them to sort of course correct without, creating a kind of a public humiliation. And, they play on different impulses. So external oversight kind of plays on the idea that we want to fight off corruption. And the sort of internal idea plays on the idea that providers have some intrinsic motivation to do better, to get their standard of care higher. I think it's possible to come up with an oversight regime that encompasses all of these goals, but it's just worth naming them and realizing that they don't all kind of cut in the same direction. We have some models of oversight in the US, but they are limited. So the one that many people are aware of is the Oversight Board over the jail in Rikers Island. They were, pilloried in the press in the last year for all the opportunities that they missed to correct the quality of care for people at Rikers, not addressing real safety concerns. But there's still a lot of things that recommend what the New York City Board of Correction aspires to. One is that they operate at arm's length from the jail itself. All of their deliberations are in the public arena. You can go and look at their meetings. You can watch them on YouTube. You can read their reports. So kind of this vision of an oversight entity doing a lot of reporting in the public domain, I think you can see it there. There's also the Ombuds person model, which many state departments of correction have. Washington State has one of the most well-known ones in the country. Since I'm in Minnesota today, just wanted to mention the Minnesota Office of the Ombuds for Correction. Under the statute that created it, it says the Minnesota Office of the Ombuds was created to promote the, quote, highest attainable standard of competence, efficiency, and justice in the administration of corrections. So probably not meeting those goals, but I think it's good to at least have state legislatures take an interest in this issue and start to get the ball rolling toward greater oversight of the operations of, correctional facilities overall and the healthcare bodies that serve in them. So to sum up, not equivalent, but better. So I think this model of Medicaid plus some kind of comprehensive oversight dramatically raises average standards of care in jails and prisons. If we were to achieve elements of this in the United States, it would be a massive victory for the ability of people who are incarcerated to have an expectation of consistent and somewhat higher quality healthcare. And, I think we're entering an era where there's going to be more experimentation. So I mentioned those 1115 waivers. And the whole trick of it is going to be whether using Medicaid funding not only just kind of floods facilities with a lot of money that they didn't have before, but whether that funding actually has a hook on how healthcare is actually delivered behind bars. Can it steer better outcomes? Can it result in a greater expectation of quality of care? Can it be strong enough to deal with those sort of long-standing structural problems in staffing and in just sort of inadequate time to treatment? Would it have, if Clayton Mcrae had been incarcerated in a jail that had Medicaid funding plus oversight, would his situation have resulted in a different outcome? I think that's the question. Beyond mountains, there are mountains. These are the Drakensberg Mountains. But this is not a panacea. So many problems of carceral healthcare will not be solved through the healthcare provider. The problems of social determinants of health in jails and prisons are very real. I think, people who spend time in facilities know that there's still the problems that contributed to propagation of COVID, including close confinement, sanitary problems, violence, noise, even the fact that many people can't get a decent night's sleep when they're incarcerated, or that they are staying in a facility that doesn't have, climate control and air conditioning, which is not just an sort of a nicety, it's actually a real health and safety problem in many facilities. And we are having this conversation kind of at a moment when we're not out of the pandemic, but we are back to sort of more normal operations in jails and prisons. But we're still basically in the same place we were at the start of the COVID pandemic in terms of preparedness for the next global event. So lots of reasons to not be optimistic about the preparation of jails and prisons for big events like this in the future. So just to recap, COVID exposed systemic failures in carceral healthcare. And one of the things that we can see clearly now is that a lack of consistent standards in the United States comes from the fact that we have a very vague legal standard that's overlaid on a system that's very fragmented and opaque and also underfunded. We call equivalence the North Star, so that is the ideal for a human rights standard for carceral healthcare. But my view is that we're not on a path to achieving true equivalence in the United States. Despite that, I think there are tangible opportunities to make progress toward something which is a more modest goal, which would be to expand Medicaid coverage and Medicaid standards into carceral facilities and to step up the role of external oversight. And with that, I will say thank you. Here's a QR code if you want to find our paper. And I'm really looking forward to taking some questions.
Thanks so much. That was great. And I'm really looking forward to this discussion period. So again, just to remind folks about logistics now, if you could please use the Q&A function to ask your questions or follow up. If any folks have technical issues, you can use the Q&A function for that as well. Very soon after this event, the recording will come available, and there's the information about how to receive the evaluation. There are lots of questions. Let me start with one. I think, I see Kayleen is about to bring us up some information about CEUs. So I talked a little bit about how to get certificates of attendance. If you're looking for CLE, so continuing legal ed credits, there's an email address on this slide that you can send an email to with questions about CLEs in particular. Thanks for that, Kayleen. So to the questions, Dr. Saloner, let me start with a question about the idea of, or the standard of equivalence, if I could. And I know that you mentioned in a way that really struck me as just so right in your talk, equivalent to what? And I'd like to invite you to expand on that a little bit, if you would, because obviously there's just there are disparities in the delivery of healthcare in the community outside of correctional facilities. And it is often noted that the quality of care and the quantity of care that is available within Medicaid is sometimes not equivalent to what other folks in the community can get. And so, you know this, I know there are sort of layers of disparities there. And I'm wondering if you could sort of tease that out and help us to understand that idea of equivalence a little bit better in that complicated context.
Thanks. Yeah, it's such a good question. And if we were having this conversation in Great Britain, it's a sort of an obvious answer. It's equivalent to the NHS. So this is exactly the problem with operationalizing equivalence in a country where there's not a single community standard. The thing that I had in mind was the standard of care that a typical Medicaid expansion member would be able to access in the place that they live if they live in a state that's expanded Medicaid. So this is a paradigm that works better in the states, the 38 or so states that have a Medicaid expansion. And it actually leaves no standard that sort of you can look to in places like Texas and Florida. But in Minnesota, there's a pretty decent, not perfect Medicaid program that has a set of benefits that members are entitled to. And those benefits are generally not available in the carceral facilities in the state. So I think that's a worthwhile thing to try to aspire to, equivalent to Medicaid.
Great, thank you. Another question that really relates to the beginning of your answer to me about if we were in Great Britain, things would be different here. This questioner wants to know, do we have data about how the US compares to other countries in terms of health outcomes for prison populations, and how access to healthcare varies across carceral settings in comparable countries?
It's so hard to get good data on the health of people during incarceration. As a researcher, the thing that I feel like screaming from the rooftops is we have no national data assessment tools to go into carceral facilities. We exclude them from all of our national health surveys. So the most that we might be able to look at is rates of kind of like death and suicide. And it's my understanding that we have higher suicide rates in prisons in the United States than in other countries, but that leaves so much kind of unexplored, unknown. And I just say anecdotally that many kinds of healthcare that we've been fighting for incarcerated people in the US, like opioid use disorder treatment, are so broadly available in the European Union. So that is just a huge health risk factor that people are not treated during incarceration, and then they come out and they overdose. So we just kind of understand this problem in a very fragmentary way.
One of the questioners then asked a question which almost was written in follow-up to the answer, although it's been sitting in the Q&A for a while. How might Medicare or Medicaid, sorry, inform or improve data and research on the health of incarcerated people?
Well, Medicaid definitely has a role to play. Medicaid has some skin in the game already because their beneficiaries cycle through jails and prisons much more often than other healthcare payers. So there's no consistent sort of practice in state Medicaid programs of tracking when members have undergone incarceration. Those of us who do research on Medicaid populations don't usually have the ability to know whether a person was incarcerated and therefore sort of what health needs they are presenting with right after they have re-entered the community. You know, like it takes a lot of data merging to get to a place where we can even look at that empirically. So Medicaid could, at a minimum, just start tracking who is incarcerated and what kind of healthcare needs they present with on the day they leave jail or prison.
Thanks. Someone else wants to know, given what little data we have, do we have reason to believe, do we have any information about how that disparity that your graph laid out in spending across states, how that might affect outcomes?
It's conjecture. So I don't think we have a smoking gun, just a lot of evidence that many states are trying to cobble together correctional healthcare using very limited substandard resources. And often this comes down to staffing. You know, one way that the budget is contained is by relying a lot on nurses, and this is by no means sort of a slight against the nurses that provide healthcare in jails and prisons. Actually, there's really outstanding, dedicated people who work in many facilities, but they're just not equipped to deal with the range of problems that people need care for. So a lot of care goes sort of like delayed when people are incarcerated.
Okay. I know you talked briefly about privatization, you know, the private groups that provide healthcare in correctional facilities. One questioner wants to know, how does that play into the ways that individuals access care? Is held to different standards than other ways of providing institutional care? And are there not already institutional or internal oversight committees in those companies to provide some oversight?
I think the companies vary a lot, company to company. I've interacted with very dedicated people that work in those companies. So actually, it's not my intention to sort of drag them behind the bus. But I think if you look at the way that the industry works, they have strong business incentives to try to compete on cost and not quality. And that from that sort of reality comes a lot of substandard business practices overall, just to generalize. And the other thing to know about this is that oftentimes when these healthcare contracts go out for bid, there's only one bidder. So it's not like there's super robust competition. There's actually not even really maybe 5 or 10 major companies in the industry, if you really look at it. And sometimes if they are found to be deficient, they will sort of pull up stakes and leave a facility and go somewhere else. So there's a little bit of a revolving door problem. And that also creates a gap in accountability that the permanent entity, which is the jail or prison itself, is sort of left to try to deal with. You know, healthcare, it's not like your average sheriff got into the business because he or she was that excited about healthcare behind bars, but they are the de facto people who often have to figure out how to provide medical services for the people housed in their facilities.
Could you comment a little bit on where the funding to pay for healthcare in correctional facilities comes from? There's a questioner who wants to know, is it taxpayer dollars, and are there other sort of options or models for thinking about how that might work? I am guessing that, just like with education, right? If you're paying for schools with taxpayer dollars, then there's going to be tremendous disparities between locations, right? So could you comment on those funding sources and the impact that that has on provision of at least available funds for healthcare?
Yeah, it's almost exclusively coming out of state and local government revenue that's appropriated to the authority. And sometimes it's not even a line item in the budget. It's just, mixed in with the other things that have to go into running a jail or prison. So highly, highly variable. I mean, it's probably a good place to just note that a very small amount of money is recouped from incarcerated people themselves in the form of co-payments and cost sharing, which, the amounts that they're charged don't seem like a lot, but people can't really earn any money when they're incarcerated. So that's often a reason why people also avoid getting medical care during incarceration.
I was going to just ask you about that, if to the extent to which those co-payments actually discourage people from pursuing care.
Yeah, they absolutely do.
Yeah. Okay. Someone wants to know about whether it would be possible to have a national oversight system for correctional facilities rather than state by state.
I think that's the vision. That would require an act of Congress to say that they are committed to standing up an oversight body like that. But I think the theory that I have is that Congress takes more of an interest in regulating different areas of the healthcare system when they start spending money on it. Certainly that was like the experience with long-term care facilities, which is not a perfect analogy, but it's another institutionalized population where once you sort of have more involvement in federal, in the federal government as a payer, they have to figure out how to regulate the industry.
So we have another question that's somewhat relates. The questioner says, to me, one of the biggest determinants of carceral healthcare is whether or not the healthcare provider reports to the same overseer as the security apparatus, since health and security often have differing goals. Can you speak to how oversight might differ based on those two scenarios, when the healthcare provider is separate from corrections and when corrections oversees the healthcare that is provided?
Yeah, it's an interesting question, and I don't have a strong view on it. I think that you can think about different ways in which it might be good or not good to have the healthcare functions and the custodial functions sort of linked together or delinked. It's good if the correctional officers are not putting their fingers on the scale about who gets medical attention, which often happens in correctional facilities for all kinds of reasons. But it's also tricky if the medical provider is sort of cut out from the political dynamics that go on with the warden and the warden's team, and if they're completely sort of autonomous, that might not be that great either, just because of the political reality that most of the clout, most of the sway is going to always stay with the custodial leadership.
Okay. So connected to that, we've had a few questions actually about the idea of trying to manage oversight and setting standards in these sorts of facilities, given what you noted in your talk and what you've noted in your excellent paper, being sort of the kind of more unique characteristics of carceral facilities. So one questioner says, for example, and I think these ideas get expressed in multiple questions, starts by saying thanks for the great talk. So I don't want to pass that comment over.
Thanks.
Questioner says, I agree with your argument about using Medicaid to set a standard, but even with a standard, there's a gap between policy and implementation. My academic medical center, the questioner says, has a contract with the State Department of Corrections to provide care, and the contract states that the care should be equivalent, but in practice, the restrictions on the rights of incarcerated patients and the constant presence of the correctional officers make it nearly impossible to provide equivalent care. Long story short, do you have thoughts on how equivalence could be enforced in practice, given those characteristics of carceral facilities?
Yeah, great question. And, as I put on my slide about whether equivalence is enough, there is a reality that when you're incarcerated, you don't enjoy full autonomy. There are certain things that could be done sort of as additional remedies to deal with the fact that we don't want people to be compromised. We don't want the medical staff to be compromised from dual loyalty conflicts. We want people to be as unencumbered as possible in their healthcare experiences to the greatest extent possible, keeping security people out of the room, stopping egregious practices like shackling women when they're, giving birth and when they're incarcerated. That's like a layer of this whole conversation. I do believe that oversight is part of the way that we deal with some of the potential disconnect between what is written and what is delivered. So I don't think it's the panacea. I think I would wager that in Great Britain, they also have problems where the custodial staff interferes with residents getting medical care, but you can get a lot of the way toward the goal just by having the standard in place and the mechanism for oversight.
Yeah, we have one participant who is sort of musing in her question about whether the fact that healthcare providers are correctional employees or at least contractors, right? And given what you've just said about correctional officers sort of being inserted in the provision of care, the questioner wonders if that creates an inherent conflict of interest that makes it unlikely that you'll meet the standard. And I wonder if you could sort of expand on that idea about it. Is conflict of interest the right sort of frame or model for us to be thinking about here?
Yeah, well, it's one of the frames. I mean, as I mentioned, there's this issue of dual loyalty, which is that when you're a healthcare provider, you have loyalty to your patient, and medical professionalism says that your sole duty should be to your patient, but you also are part of the surveillance and oversight apparatus of the criminal legal system. So will your patient be as forthcoming as possible? Will there be a risk that the things that you document in a medical record will be used again? I mean, I think that these are real, not fully worked through conundrums of professional medical ethics that arise, and like NCCHC oversight anticipates that this is going to be a problem and lays out some avenues to try to insulate the healthcare provider from being tampered with, as it were. But there's other potential frames other than dual loyalty. One other thing that I would say is that you can also try to chip away at this problem or make a little bit of progress by working on the custodial staff themselves. It's not like all of them all of the time have to only be approaching their job through the kind of security lens. They also can play a role in caring about the health care of incarcerated people. One of the things I've actually learned in my work on opioid use disorder treatment is that you can win over custodial staff for raising the standard of care by convincing them that it helps them to do their jobs better. Facilities where patients are treated and not in withdrawal are safer facilities. There's fewer violent incidents. There's less kind of chaos just day in and day out. So getting patients better care, arguably is consistent with the goal of having a nicer place to work. So I'm not totally down on the possibility of trying to also work on the custodial staff.
Sort of changing perspective or changing culture in a way.
Yeah.
Yep. Yeah, that's interesting. one questioner wonders whether it might affect other populations negatively to devote more resources to correctional facilities. So does that potentially divert resources away from other underserved populations? And like you and I, before the talk started, had this conversation about trade-offs, right? And this is sort of one of those kinds of questions in the real world. Is the sort of thing that you're proposing, potentially, does it have costs elsewhere?
Yeah, and I don't want to avoid answering that question head on, but if that's the fundamental concern, one remedy is trying to curb mass incarceration, because then all people become a community health problem. So I think that there's a sense in which we kind of artificially make these distinctions between healthcare behind the walls and healthcare in the community. A lot of things that happen behind the walls spill over into the community when you don't treat someone's diabetes when they're incarcerated. That becomes a problem in the community. It ties up resources in emergency rooms. It makes someone a harder patient at an FQHC. So, these are just sort of general things I can say because we don't have really solid data to sort of quantify whether these trade-offs actually exist. But I think it might be worth at least contemplating that if you provide better healthcare in carceral stays and you try to make carceral stays shorter, that you actually could be doing something to benefit community health.
Yeah. One participant makes a sort of related point, but I think this point is also broader. She says Medicaid waivers and financing seem critical. States need the federal dollars, but then again, doing this state by state is going to result in a patchwork, right? So having a broader implementation of those Medicaid waivers would also, wouldn't it address the kind of consideration or concern that you were just addressing in the last question? But obviously the implications of that go even beyond that concern about trade-offs with the community.
Yeah, I would prefer to see this happen nationally. I think the perennial question with Medicaid waivers are states really the laboratory of democracy? Like, in other words, do we learn from what happens when we grant waivers to some states, then use those lessons in national models? I actually think in this case, there could be some really constructive learning from the first few states that get waivers about how you actually devise a correctional healthcare benefit that mirrors Medicaid, because there's all kinds of very in the weeds kind of technical things to work through, like how do you say that the formulary is adequate? How do you say that staffing in a correctional facility is sort of at the level that a Medicaid managed care organization would be held to? What do you do around coordinated reentry? Like, no one's ever tried to work through these challenges because we've never had the funding model to do it. So we got to try it and then see like what is more or less successful.
So next question is, from your point of view, what are the next steps to actually implement the Medicaid expansion in a more centralized oversight entity? So can you talk in a little bit more detail about practically how we would do that? And let me tie in a couple of other questions I saw above about this, which is, what can we do to help? A bunch of people are saying, as a student, what can I do? As a health professional, what can I do? And I'll just give you a little context. This is often an animating conversation at ethics grand rounds. People want to know how they can use their position, whatever it is. It's a fairly diverse audience, to sort of move reform forward.
Yeah, it's a great question. I think start local. So wherever you live, there is a jail in that place. So try to educate yourself about what the oversight situation is there. If you have the ability to sort of like attend public hearings, try to see what's going on, just learn about what's happening, because it's a civic issue for every community. It's just one that the broader community isn't always sort of in the know on. And that will naturally sort of raise questions. If you're a healthcare provider, consider providing healthcare for incarcerated people. If you are a student, consider being part of a tutoring program in the jail or prison in your community, or helping people during reentry. I think there's a lot of things we can do as individuals to take more of an interest in these problems and the incarcerated population. I think to the kind of the policy question, if I were a state Medicaid official, I think I would be, and I was in one of these states with a pending 1115 waiver, I would be trying to work in real time with all of the parts of the healthcare ecosystem that have to get stitched together to really kind of work through models and care pathways. So all of this is going to fall on implementation. And I think Medicaid should extract some promises from carceral facilities that if they are going to be present and spending money, that carceral facilities have to meet standards. You don't want to set the bar so high that they can't meet the standards. And there are some local jails that if you set the bar really high, they don't even have an infirmary. So you have to be somewhat pragmatic, but really coming up with detailed plans for, okay, what would a managed care contract encompass, and what would the payment rate be set at, and who would be at risk in this contract, and what are the quality incentives that we want to monitor, and all of these kinds of very in the weeds policy questions. Getting all of that stuff right is mission critical right now, because that will determine whether these models actually take off and succeed.
Yeah, that makes a lot of sense. Let me shift focus a little bit away from that to thinking about just provision of care in correctional facilities in general. One of our participants really wonders about the degree to which sort of stigma around some of these conditions, like substance use disorders or mental health conditions, for example, or just sort of cultural conditions in the facilities that might relate to sort of ways in which disclosure of health conditions might negatively impact sort of the day-to-day life of the person who's incarcerated. Can you talk about how to address some of those sorts of worries that, even if care is available, there may not be uptake or appropriate uptake in a way?
Yeah, it's so true, and it's experienced so vividly by incarcerated people. There's a double stigma to having some of these conditions. There's the stigma of incarceration itself, and then there's the stigma of your disease, and these are intersecting stigma. Probably the best ways I've seen of overcoming the stigma have been to really try to commit to culture change in the facility. So in the, again, it's the example I come back to because it's the one I know best, but treating opioid use disorder in carceral facilities, a lot of facility staff to help them understand that addiction is a chronic disease that can be treated with medication, and that there are effective medications, and that basically you need to get with the program. There is a slight advantage that facilities sometimes have with winning over the staff, which is that kind of they are in a hierarchical kind of almost military or police type structure. So if their leadership tells them to make certain changes, they will make those changes. So really making sure that there's no harassment, intimidation at a minimum, and that people try to kind of create norms of supportiveness for getting treated, and seeing that as a way of making people successful. I'd like to think that we can appeal to people's better angels, and that the idea of rehabilitation, if that's something we take seriously, starts with treating people's illnesses during incarceration. There has to be some benefit to that.
Thanks. So let's shift a little bit to thinking more broadly about sort of public health issues. I know this is where you went at the end of your talk. You talk about this in the paper a little bit as well. One of the questioners notes that less than 5% of US healthcare spending goes toward public health efforts. and says the spotty and inconsistent response we saw from public health during the COVID pandemic may be related to that lack of investment. That makes a lot of sense, right? So how do local public health efforts generally translate into the care or lack of care for incarcerated persons in the context of the pandemic in particular? And then I want to follow up with just some more general talk about more public healthy type things in facilities. So can you start by commenting on sort of pandemic response?
Yeah, so we did all these interviews that I didn't talk about today with people who work in facilities and in the system in general about how they dealt with the pandemic. And a lot of what we heard about was them just making things up on the fly because they had no, consistent national public health guidance. The CDC eventually put out some guidance that was non-binding on carceral facilities. They struggled in many states to get basic resources like PPE and masks and whatnot. So there were a lot of like jury-rigged solutions. I'm not trying to let them off the hook, but they're often sort of getting scraps at the table when it comes to public health decision-making. So there has to be an aspect of saying that our public health in whatever community we live in encompasses the incarcerated people in this community. And if that idea is really central, then we would empower public health authorities to also regulate and have oversight over carceral facilities. So like that exists on a limited scale in some places, but usually the community public health authorities don't have a very large footprint in carceral facilities. If they did, they might play a wider role in sanitation and in environmental conditions and, thinking about nutrition and climate control and exercise and all of this other stuff that makes us healthy. Like these are really often afterthoughts in carceral facilities.
So let's think a little bit more about that, because that's also where I wanted to go. We've just got a couple of minutes left. So briefly, other things that we can do, obviously, to promote better public health also would promote just sort of better health in general, right? Better ventilation, better quality facilities. You mentioned sanitation, addressing violence. All of those sort of structural or contextual factors really can impact the health of the people who are incarcerated. And I wonder if you might comment on how we can do better with some of that stuff. I mean, I had conversations with our commissioner of health our commissioner of corrections during the pandemic. And, he said to me, I mean, there's only so much you can do with ventilation when you have these old, buildings that are so difficult to work with, for example.
Yeah, my quick answer, because we don't have much time, is pay for it like it matters and measure it. Like if we don't measure this stuff, then we don't see it and it becomes invisible. So we've got to make some of these problems visible.
So it's true that in some sense that these are issues and that there are limits, but there needs to be a bigger, broader policy solution as a public health and policy solution, is what you're saying.
It has to be part of our public health imagination to start.
Right. Yeah. Thank you. So we are pretty much out of time. Really appreciate you joining us today. It was a great kickoff to this year's Ethics Grand Rounds. For those of you who are participating today, I just want to call your attention to next month's event. Dr. Kamisha Russell from the University of Oregon is going to be here to talk to us about the case for reparations in healthcare. Should be a really interesting and potentially really controversial event. And we are really looking forward to that as well and hope to see many of you there. So again, Dr. Saloner, thank you very much for your time. And thanks to all of you for joining us. See you next time.
Thank you so much.